Good afternoon, everyone. Thank you for joining us. We'll get started in just a few moments as we have more individuals joining us this afternoon. So thank you for joining us. And while you're all getting situated joining the webinar, if you could take a moment and type in that chat box how you're connected to this topic. You could be a professional, you could be someone who uses the services provided. Let us know how you're connected. So thank you for typing in and letting us know how you're connected. We have some case managers in here, therapists, folks who work in the justice system, staff. Looks like we're still getting a few people trickling in, but we will go ahead and get started this afternoon. My name is Sarah Tunnell, and I am a project manager at the Healthcare Authority. This webinar is being recorded. All participants are in listen-only mode right now. We ask that you use questions using the chat box. However, we will also have a Q&A session at the end of the presentation where you can raise your hand and ask questions or put your question into that chat box. A copy of the presentation will be sent to all participants by June 3rd. And we have multiple presenters today coming from different agencies, and we're all working from home right now. And if you have any trouble hearing a particular presenter, please use that chat box again and let us know if you're having some trouble. So for just a little bit of background, the work of this particular work group started before January 2020. And in light of the current world situation and the changes due to COVID, we are presenting this as information only, and we will have to wait and see how things progress over the next year before we submit any budgetary requests. So next up in the presentation today is Nicole.
Hi, good afternoon, everybody. My name is Nicole Jensen. I work for the Developmental Disabilities Administration, and I am going to start us off by providing a little bit of background information about our work group.
Next slide.
So originally, the purpose of our work group was based upon the Health and Human Services Subcabinet Committee asked the Assistant Secretaries and Secretaries and Director of Healthcare Authority, the Developmental Disabilities Administration, and the Department of Children, Youth, and Families to create a work group to address ongoing service delivery issues for children who are in placement or those who are at risk of placement within the child welfare system. The scope of our work focused on meeting the service and placement needs of children and youth who experience both developmental disabilities and behavioral health challenges. What we identified was that there were multiple systemic shortcomings resulting in unnecessary emergency department stays, out-of-state placements, hotel stays, and single-night foster home placements. Next slide. The different presenters today include representatives from the Developmental Disabilities Administration, the Department of Children, Youth, and Families, representatives from Healthcare Authority, and the Office of Financial Management. We had other work group participants included that are not presenting today, including individuals from the Department of Health, as well as those from Aging and Long-Term Services Administration. Additional stakeholders and partners invited to participate in our webinar include, but are not limited to, community advocacy organizations, managed care organizations, behavioral health organizations. I know that we have parents and caregivers joining us today, those providing natural supports, youth, as well as our providers. So welcome. Next slide.
Next slide. Next up is Rihanna.
Can you hear me now?
Yes.
Okay, great. Thank you for the opportunity to speak here today. I'm just going to quickly go over the decision package timeline with everybody. The slide in front of you is pretty much the basics of how it works, but before I get into it, I just want to go over a little bit of verbiage with people. When we talk about a state fiscal year, we're not talking about the calendar year, so we're talking about July 1st through June 30th. And just to give a point of context, right now we're in state fiscal year 2020. In July, beginning in July, we will switch over to state fiscal year 2021. So when we're talking about decision package timeline, we're talking about decision packages for two things. For state fiscal year 2021, this would be considered a second supplemental. It's the last opportunity for budget changes for state fiscal year 2021, and then also building the biennial budgets for state fiscal year 2022 and 2023. So the first major deadline is at OFM. We will put together budget instructions, and we will send those out to agencies. We tend to do that mid-August. Then agencies will submit their decision packages and request legislation to OFM in September, and we do not have a specific date for that yet. Then we review the decision packages in the fall, and we work with the governor to make decisions on what decision packages and request legislation will be moved forward into the governor's proposed budget to the legislature. Typically, the chairs of the fiscal committees will sponsor the budget bill for the governor's proposal, and any request legislation can be sponsored by any member of the House and the Senate to move forward as a bill. And these tend to go in tangent, though sometimes the timelines may vary. Then the legislature will convene. The legislative requirement by law is January 11th. And then in between this time, you'll see a number of forecasts coming out, and these forecasts will be for caseload and for revenue forecasts. The first one is this June, and then again in November. The November forecast will help with the building of the governor's proposed budget, and then another one in February, which tends to be the final budget that is utilized by the legislature, the caseload forecast that's utilized by the legislature for the final budget. So if all goes well and we do not have a special session, the legislature would end and sine die would be in April 2021, and the governor would sign the budget in April as well. So the thing about decision packages, they are requests from the agency to the governor, and they are public. They can be found on the OFM website. They are an ask to the governor. There's no guarantee that a decision package will be funded or that it will be funded in the way that it was requested. I know that I have very little time to talk on this subject, but I just really want to point out as we're going into the next budget bill, we are facing a revenue crisis related to COVID-19 and a downturn in our economy. So we're projecting unofficially with the revenue forecast of about $1.9 billion shortfall. And so what that will mean is that as we move forward with the budget bill, OFN is also looking at requests to the agencies and working with the agencies to identify areas where we can help reduce the shortfall. So those options can include anything from scaling back to delaying implementation of a program or a project, and full-on reductions. And while some of these, we loosely refer to them as cuts, they will be difficult, but they will be unavoidable. So this is a challenging time to be moving forward in budget requests that would start something that would be considered new when we're looking at scaling back. The bright side of this is there's a little bit of good news in that the revenue forecast assumes an uptick again in the next year or two as we make assumptions about the reduction in COVID patients and the potential for a vaccine. And with that, I will go to the next slide for the next presenter.
Next, we have Jenny.
Thank you. Excellent. Hi, everyone. This is Jenny Hedden. I am the Chief Financial Officer for the Department of Children, Youth, and Families, and I've been participating on this work group since its inception. I also just like to provide the context that outside of my work, I am the mom to an autistic 5-year-old, and so definitely understand the importance of many of the services for the clients that we serve and for families in general. So we went through as a work group and identified a variety of needs, but again, I always think about this, that this is from our perspective largely as implementers and statewide administrators of a variety of programs. And so part of today's effort is also to get some feedback about where everyone else sees the gaps and how well we did in identifying some of these major needs that we have. So I'll just go through these briefly so we can keep moving through the presentation. But some of the needs that we've identified are services that are sort of between some of the care levels that are currently available, and you'll sort of see we have a kind of a stair-step conception of levels of care, levels of intensity in the state. And a lot of times what we see is challenges around stepping up into a higher level care or stepping out and down from that higher level of care. So really trying to figure out ways to have actually more levels and more stair steps between some of the levels that we have currently. Behavioral health respite for children and youth with challenging behaviors, obviously a huge need that we hear about frequently across many of our systems. Habilitative mental health inside the children's long-term inpatient program. So right now under the CLIP program, typically, and actually many of our mental health services, there can be a disconnect, you see this on the next bullet, for children that also have a co-occurring intellectual or developmental disability, that there's challenges sometimes in provision of mental health services to those children, and particularly around staffing that are actually trained in both areas of service. We experience on my side of the house at DCYF foster homes, a lack of foster homes that can serve youth that experience complex challenges. So you have youth entering the foster care system that have intellectual disabilities, developmental disabilities, mental health issues, and trauma on top of it. So very complex challenges. We recognize also that many of our systems are designed around a child focus, but we know that children live in families, regardless of what those families may look like and be impacted. And so how can we move out to more of a family focus instead of a specific focus on the child or the specific eligibility program that we're running, so we can wrap around a family more. Information about how to access care is challenging. Again, I can speak to this wearing both hats, hearing about it as a chief financial officer, but also experiencing my own challenges around accessing the right and appropriate levels of care. Again, that sort of early provision of a wraparound team for families that can take care of, again, rarely is the child the only one experiencing an issue. That's usually impacting the family as a system, and how do we wrap more around those families and support them. Behavioral care / sort of urgent care. So the idea, this is starting to, I think, come up more, but has been a challenge historically, is that you tend to have to be on a sort of longer waiting list to get access to behavioral care, or you need the emergency room. And can we develop more options that look like an urgent care model for behavioral issues? Transitional care between settings and needing more of that intentional transition service. So that kind of speaks to those earlier bullets that we talked about of like not having enough kind of ability to move between, and then also how do we really do a better job of being more intentional with those transitions. And then developmentally appropriate services, having a wider array of those available. Next slide. A huge issue for especially those in the autism community is having access to applied behavioral analysis, ABA providers, especially for older children, ABA providers who take older children. And again, an inability to deal with some of those behaviors leads to these families entering a crisis state when they hit some of the deeper ends of our mutual systems. Reimbursement rates for providers need to be high enough to incentivize actually serving our client group, and obviously rates are a huge issue across the board. More infant health consultation and more in-home visiting, and just more services available statewide. So we definitely have issues where we have services available, but they may not be available in rural communities, for example. They may not be consistently available across the entire state from east to west side, for example. So, or you may have one type of service in one area and a different similar service in another area, but you can't access everything across the entire state. More secure inpatient treatment settings, a discussion that Washington State tends to be on the low side of the number of these available, and that inability to have those secure settings creates, again, challenges thinking about the purpose of this group, really focused on impact to the child welfare system and multi-system involved youth. Not having access to that secure inpatient treatment when appropriate can create challenges throughout the system. Always wanting to work on expanding our array of services as it relates to culturally and linguistically responsive and appropriate services. So again, kind of going back to that, we don't have it everywhere, every service we'd like everywhere, and nor do we have it available in every language and culturally appropriate services available. Creating more low barrier walk-in services. Again, just recognizing that families enter into a crisis and that we need to be able to sort of lower that threshold and not be bouncing families back and forth between different systems and eligibility processes. Building system of supports for parents and caregivers to improve parenting skills for individuals with intellectual disabilities and behavioral health concerns. So the way I always frame this one is that as a special needs parent, I have to bring my A game to every day. I don't get to bring my C game to the table. And so how do I, as a caregiver, gain skills that help me manage behavior in the home and in that family system so that I don't have a situation that down the road results in my child needing higher and higher levels of care. And then more behavioral rehabilitative services, or BRS as we call them in DCYF, homes that support children with intellectual disabilities. So again, looking at those children and young adults who may have a combination of issues with behavioral health and intellectual or developmental disabilities, that combination results in a real challenge around our mutual systems being able to serve those individuals. And so how can we build more things in that space? Next slide. So this is our sort of idea of our continuum of care, and you'll see us as we sort of present and try to ground everyone in so that we're all in a sort of common framework for this webinar. We have sort of again these stair steps. So we start at prevention, we move to early intervention, brief intervention, basic outpatient and community services and supports, intensive services, and then that acute or inpatient setting. And that really this is, we actually went round and round as a group about how best to demonstrate this continuum of care. Is it a stair step? Is it a circle? How do people flow? But really that you do increase your level of intervention. As a CFO, I'll also say you typically are increasing your costs as you move up this this stair, but that people should be able to move between fluidly as possible into any of these steps that meet their needs at that moment. And that is obviously not a system that we have today, and one that we would like to achieve for the children in Washington State. Next slide, and I believe I'm handing it off to Gail.
So hopefully you can hear me. I'm having some connection problems. Can you let me know if you can hear me, Jenny?
You're
I can hear you.
Okay, so Jen, if I cut out, it's because something happened, and I'll need you to assume for me, okay?
I'm happy to do so.
Okay, thank you, Jenny. Hi, this is Gail Krieger. I am the section manager for the section in the Healthcare Authority responsible for managed care, and work with my colleagues here on this project as we develop a plan to better serve our clients. Jenny explained the continuum of care and how the stair steps worked in our model that we were envisioning. I'm going to review each of the stair step topics. The first one we're going to cover is prevention. I'm not going to read all of the content to you, but just to explain how this is laid out. The first stair step would, again, be prevention, and what we're describing here are the current services as the members of the committee saw them. Some of these services are available in more than one of our delivery models, whether it be through DCYF, DDA, or the Healthcare Authority's Medicaid benefit for behavioral health and physical health benefits. And some of them are may only be covered by one of the agencies within the system. So we wanted to share with you that this is how we identified services that we felt were addressing the provision of services that could be classified as prevention. Next slide, please. This slide represents the second tier on the stair steps of early intervention. This slide goes a little bit more into significant detail because as we were working on the model and as we were looking at the gaps, this is an area where we saw an opportunity. You can see our current services are listed to the left, and then we have our presentation to you all, or our sharing of information with you all in regards to what was funded in this current session that just completed in the spring. We did receive funding for a program called New Journeys, and it will address providing intervention for individuals with first episode of psychosis. So we were pleased that that was funded. And then we identified some other long-term solutions that we want to pursue in the future. We recognize that there are services available, but we felt that there was a need to increase access to the applied behavioral analysis services, that we should look at requesting an opportunity to increase access to our children's intensive in-home behavioral support waiver, that we would increase the number of options or number of individuals who could be served, that we wanted to increase the basic plus waiver slots that are also part of the DSHS delivery model, and that we wanted to provide training to DDA respite providers, supporting them in additional training that would help them provide behavioral support strategies and expand the services they could provide. So those were the things that we wanted to focus on this slide. So Jenny, do you want to do the poll?
This is Sarah. I've got the poll.
Oh, sorry.
That's okay. So to help us determine what you would like to prioritize for this work group going forward, we'd like to know what you think should be, what is on your top priority. So if you could take a moment to vote. And we have about 35% of folks who have voted so far, so we'll give it just another moment. Okay, it looks like I'm going to give you 10 more seconds and then I'm going to close that poll. Thank you, everyone. So it looks like at this point there was a bit of a split, although it was fairly close. 49% of you think that we should prioritize increased access to ABA services, and 36% would like us to focus on DDA respite providers. And then the other two options have a much smaller voting percentage to prioritize. Thank you.
Let me take it back, Sarah.
Yes, please.
Okay, thanks everybody for participating in that poll. We really appreciate your input. So then moving forward, the next step on the steps is brief intervention. With this particular level of care, we did not identify any gaps. This is an opportunity where you could let us know if you believe that there's possibly a gap in current services that might be classified as brief intervention that would help us round out, if you would, our recommendations. But we felt that the services that we have available were meeting the need, and that in terms of other initiatives that might have more priority, we wanted to focus on those others as we're going through them today. But possibly if you have something that you would classify as a brief intervention, when you look at this list and you'd like to add something, we would invite you to contribute to that for us. Next slide. Next ladder step is basic outpatient and community services and support. You can see here that we've identified the current services, again, across the 3 agencies. We identified long-term solutions that we felt we needed to pursue that would contribute to providing additional outpatient and community services and supports. Again, this includes increasing access to applied behavioral analysis, because that is an outpatient program. We want to pursue an enhanced transitional living model. This would be for individuals who were transitioning out of foster care between the ages of 18 and 21. Again, we wanted to add SIB waiver options and services. We want to pursue a residential home setting with treatment support. This is a system that is a system of care that's currently being funded by a grant, but we want to pursue state funding with federal match so that we can continue to provide that service. And then again, we thought we would pursue increasing basic waiver plus waiver slots with the enhanced respite provider type training, so that those individuals were skilled in providing ABA services and other behavioral support strategies. So Sarah's going to pull you again for input in regards to what you might see as being the priorities from our solutions that we're proposing. Sarah?
Yep, so here is your next quick poll. Out of these long-term recommendations for basic outpatient and community services and supports, what is your top priority? And we'll give you a minute on this poll as well. So while you're still working on that poll, we'll just keep it open for about another 10 seconds. Right now, we have residential home setting with treatment support coming in as the top priority for this, with the other three being distributed pretty evenly amongst the three of them. So I'm going to close this poll now. Thank you.
Back to me, Sarah?
Back to you, Gail.
Okay. And then the next ladder, our step on the stairwell, is intensive services. We have brainstormed this set of current services that are available across the three agencies. We want to acknowledge that we received budget supplemental support to increase SOLA beds for children by 6. We also received legislative support and funding to pursue hospital-based intensive outpatient and partial hospitalization pilots. So those are in the process of being developed as well to provide services in that setting in lieu of inpatient or a community-based setting. And as we looked at what we had been approved in the second shape underneath supplemental budget and looked at what our current services were, we felt that the one idea that we needed to pursue here under this intensive services heading was additional SOLA beds that more than the 6 that we were allotted would actually meet more of the demand that we currently have for clients. And so we would ask for additional SOLA beds in a long-term budget proposal to help solve the problem and provide services. And we want to thank the governor and the legislature for what we did receive last session, because the 2020 supplemental budget initiatives that you see there on this screen are very meaningful in contributing to the direction that the agency wants to go in regards to providing services outside of the institutional setting. And I would offer that if there are additional long-term solutions that you might see under this heading of intensive services, we would appreciate any input that you might have in that regard. We would welcome that input. Next slide. Our last slide is acute and inpatient services. We've laid out our brainstorming in regards to what we saw as the current services that were available. The reference to state hospitals in that first, I'm going to call it a rectangle. I'm not sure that's what it is or not, but that first rectangle where it references state hospitals ages 18 to 21, that particular language or those particular words are addressing Western State and Eastern State hospitals to make sure everybody understands that's what we're referring to. We did receive funding from the 2020 supplemental budget, and we have, as well as we have a substance use disorder initiative to be implemented in 2020 that will be around secure withdrawal management and stabilization. We have 3 initiatives from the supplemental budget, adding 20 beds to our BRS Plus program, 5 beds to the BRS Plus Enhanced program, and 12 beds for Enhanced Emergent Placement Services, which is an additional program. So that was quite a contribution to where we felt we needed to go in the big picture of providing services to our clients. What we are seeing as potential long-term solutions that we are wanting to work towards are a Hawaii model, which I'm going to ask Diana Cockrell to describe for you all, but also I'll finish this slide out, or finish this little rectangle out first. We want to provide habilitative mental health services in a different setting than they're currently available. This is a program that's available at Western and Eastern State Hospital at the civil commitment wards, and are designated for and designed to provide support needs for patients who have developmental disabilities as well as a coexisting mental health condition. In addition to the psychiatric services that these patients are provided on those units, they also receive a wide range of habilitative supports which benefit those patients. Those supports include personal care, community access, and vocational activities. So we would like to provide those services in settings outside of those 2 hospital settings, such that they might be available in the CLIP environment. And then we also want to propose what we're referring to as a DCYF transitional services. This is a service whereby we want to support transition from for a child who's in one setting as they need to move towards another setting, and to be able to pay for both of those placements at the same time, regardless of that whether the child has moved to that receiving setting, to keep that provider, to keep that receiver engaged and participating in that plan, and reimbursing them for that commitment of time that they're making to support that transition. Diana, are you available to talk about the Hawaii model?
I'm here. Thank you, Gail. Can you hear me okay?
Uh-huh.
All right. Thank you. Diana Cockrell, Healthcare Authority. I am a section manager and support the teams that work on child, youth, and family behavioral health. And so the Hawaii model, colleagues of ours in Hawaii are actually modeling this as we speak. So the idea is that it is a state-operated 30 to 45-day evaluation and stabilization facility with no option for refusing youth that need the services, staffed by behavioral health and intellectual and developmental disability and foster care experts, based on what the need of the population that is being served at the time needs. The goal of this one, or the idea behind it, is to reduce, if a shorter term stay can reduce the need for a longer term stay, that is one option, and or if there's a step down needed from long-term care back to the community. Also help with reduction of the emergency room stays, and provide supports earlier if needed that are appropriate for the youth and family. And I think with that, we're ready for the next activity.
Yep, so next up we have another poll. So based on those long-term recommendations for acute and inpatient care that you just heard us review, what is your top priority? And I have heard from a few people in the chat box that they were having some trouble voting. So if you had some trouble, you can type your response into that chat box and we will record that. So I'll give it about 10 more seconds. Without counting those written in ballots, just going by the percentages, we have we have a very close even split between the Hawaii model and the DCYF transitional services. And then next up is that habilitative mental health. So I'm going to go ahead and close this poll. And we can go to the next slide. So next up, we have yet another polling question for you to help us figure out. We've gone over this continuum of care that Gail just reviewed with you. And we'd like to know, based on that continuum of care, which area do you think needs priority attention? So we went over the early intervention steps, brief intervention, basic outpatient and community services and supports, intensive supports, and acute and inpatient. And I'll give this about 30 more seconds while those votes are coming in. Okay, I'm going to give it about 15 more seconds while you're still getting those last minute votes in. Right now, in first place for prioritization is looking at our intensive supports. And then coming in after that is our basic outpatient and community services and supports. So I'm going to go ahead and close this poll. Thank you. And we have some questions for you. Did we miss anything in our identified needs and gaps in services? And do you support our long-term recommendations that we've presented here today? You can type your questions or feedback into the chat box. And just please note that we are unable to answer any child-specific questions during this webinar to protect the privacy of children and youth. And to answer your questions and respond to comments, we have a panel today from the Developmental Disabilities Administration, the Department of Children, Youth, and Families, the Healthcare Authority, and the Office of Financial Management. And so we have been collecting some of these questions as the webinar has been going on from the beginning. And so Melanie, would you like to ask that first question?
Absolutely. Let me go back. And we're just, we're going in order chronologically. So this, that has nothing to do with how important we think one question or another might be. But if we run out of time, because I know that there's a lot of really meaty discussion that will probably result from these questions, then we will make an effort to answer them offline as well. So the first question that I think applies to everyone is what came from Penny Quist. And it said that one other request of budget is that we do not have the workforce to sustain the needs of service. One idea is to use funds allowed for education to relieve student loan debt to those going into the mental health and SUD fields. So would one of our SMEs like to address that?
So this is Gail. Can you hear me?
Yes.
I think that's a really good point. And I think that I have participated in other forums where this has come up as a opportunity and a solution for the challenges that we have for a workforce. And so we will take note of that thought. And my viewpoint would be the more consistent messaging that we have from the different resources and sources and forums that we've convened, then I think it's more meaningful to the listeners, which in this case would be the legislators. So let's take note of that and think about how to incorporate that into our recommendations.
So another question from Penny that is related has to do with the passing of House Bills 1874 and 2883. Have we invited any facilities that already have models, tools, and experience to bring their supports into Washington to help our most vulnerable children for placement within the state to maintain family connections? And I know we may need a little more context on that one, so that may be one we have to answer offline, but if you can, Gail, is there anything you would like to say regarding that?
I don't have those bills freshly in my mind, and no, I don't. I'd have to study that a bit before we could respond with intelligence.
Okay, no, that's what I figured. So Penny, we will get back to you on that one. I've noted that, and we'll do a little more research before we have that discussion.
Yeah.
All right, let's see. So we have another question from Penny. It's what acute and inpatient services does Washington State currently have for our children? And she specifies for long-term needs beyond CLIP.
This is Diana. To my knowledge, CLIP is our long-term option for residential placement, but I'm wondering through DDA or child welfare if there's if there's something additional.
Melanie, this is Nicole from the Developmental Disabilities Administration. And just before responding, would you mind just rereading it again? I want to make sure I understand the question being asked.
Yeah, absolutely. It's what acute and inpatient services does Washington State currently have for our children for long-term needs beyond CLIP?
Well, this is Nicole Jensen. I'll just speak on behalf of DDA. We don't provide acute inpatient treatment, long-term treatment for children. And refer back to Diana, who indicated that CLIP is Washington's long-term inpatient treatment that we have currently.
Okay, great. Thank you, Nicole. Oh, sorry, Gail, were you about to say something?
Yeah, I think that we listed the current services. We do provide SUD treatment. We have freestanding psych hospitals for treating psychiatric needs. We have the CLIP, as Diana discussed. We can provide, we reimburse for services that may need to be provided in the emergency room, which would and oftentimes is a triage setting, and then a child may be transferred to another facility. We recognize that that there may be a need for additional services, which is why we have a long-term solutions proposed, and it's why we requested the additional beds that we did in the 2020 budget. We need to continue to work on building the supports that we need within our system here in Washington State. There have been also children who have developmental disabilities that we reimburse for their services out of state. There are facilities out of state that aren't available in state, but we still have access to them by recognizing them as a tool in the toolbox, if you would. And we will approve children to go out of state, and we will pay for those services if that service is needed. It's deemed medically necessary, and it's not one that we can access in our state of Washington. So I think that's the whole point here, is that we're recognizing we're having more experiences as we work with children and families. We're seeing where our gaps are, and that's the whole point of the webinar, and to develop what we're calling this long-term plan with solutions so that we can build what we need.
Okay, thank you, Gail. So the next question that we have is from Peggy Dolane, and she's wondering about subacute inpatient care and why that was not in the continuum.
So can they be more descriptive in regards to what that term means, subacute inpatient care?
I can unmute if that would be helpful. Peggy, would you like to clarify?
Sure. I got this term subacute from a medical doctor, and I think there needs to be a distinction between that we don't think about in our continuum of care. Acute care is hospitalization, like at the PBMU, where you have a suicidal person that cannot be safe out in the world. Subacute care is something that is a much longer term solution, where, like, I spoke to Libby Hine, and I think she from Molina, and I think you would want to, if she's on the call, she may be able to add some more to that. There's a number of people I've been speaking to about this issue, but like, there's a range of things that can be offered. There's wilderness, there's therapeutic boarding schools that can be in in town. There's the just standard residential program where you can learn to apply dialectical behavior therapy. I mean, some children are too young to be able to learn these behaviors over a 6-week period in an outpatient setting, and really need a longer term, but they're not suicidal or a danger to others. That's what I'm talking about. I don't see you capturing that at all.
So that would be one of your long-term solutions that you would contribute, is that we need to look at something slightly different than the 3 bullets we have under acute and inpatient?
Yeah, I think there's a huge gap in service of, wilderness can be an extremely beneficial kind of program. It's 13 weeks, it's outdoors, which meets cultural needs for some communities. It's really different. Adolescents get out of what, they're not in an institution, but they're in nature. That's a completely, we've never spoken about that as a kind of option. I know there are children that can never be safe. I know there's a parent or two on this call that feel that their children are not able to be safe out in the world, but don't want to send them far afield, and have failed out of all of our habilitative mental health, whatever that means. That they're, and I think there's parents that can give you ideas about what those, we think of acute, and then we think we don't want our children in institutions, and there's a lot of other things. And I do think that stabilization and assessment facility is also can serve as a subacute facility. So it's complex, and I really like all your needs that you identified, but I'm not sure how we're threading the recommendations to fit those needs as opposed to threading recommendations to existing funding. I don't think we quite got the logic model in place yet. Thank you for listening.
Yeah, thanks for the contribution.
Melanie,
Right. Yes, give me just a moment. Let's get to the next one. All right, so this next one is also from Penny, and it says, can families be supported as they support their youth in the residential setting, coming out of inpatient care and transitioning into adulthood, like these treatment services requiring many more persons to manage do? Sorry, I don't think I fully understand it. We might want to have Penny speak to it.
okay. Just a moment while I find Penny and unmute her. All right, Penny.
Hi, so this is Penny Quist. I'm in Grant County. I've been on multiple HCAs. I believe Swazi was on one of them, and they were talking about the monies put out for these transitional support services for our kids coming out of situations like inpatient care. And there's a lot of support systems and transitional housing and caseworkers and different settings set up to help them do that. I'm a mother who is willing to stand by my child and help them go through those transitional pieces. And I'm here for the long haul. I don't require to be the caseworker, the transitional housing, the person that's going to come in and check on that. So you're going to take 5 people for this caseload for a child, or you're going to take me, his mother. So why can't we take those fundings and assist me to be his transitional support? Because I'm in it for the long run. So we have these transitional support programs set up for these programs out in the community, but what are we doing to support the families who are willing to be that transitional support?
Penny, this is Jenny, and I know I'm sure other people will speak as well, probably specifically with some of the services that your family's interacted with. I think you're bringing up a good point, and one of the things that we sort of pointed out in our needs assessment, which is that we probably don't collectively do a great job in looking at that whole family system, and certainly one of the values of the child welfare system is to recognize all the supports that a child may have available to them. And so I think, the logistics of exactly how you do that and how you work that out with funding sources and requirements, and especially federal funding sources in the mix, is always challenging. But I think, you're definitely highlighting one of the pieces that this group has had extensive conversation on, which is how, instead of just layering services in, how do we really best support families to meet their own family's needs and their child's needs, especially if that child's needs are complex, and how can we help support that? And right now, I think that there's a big gap in that. We just don't have a lot of programs aimed in that direction. And so definitely recognize your sentiments here.
Thank you. It is a full-time job to support my child, and I have 5 other children to support as well. But he is a full-time job.
All right, so I think we have time for one more, and then we will attempt to answer the other questions offline. So we have a question from Hana Sen. I apologize if I pronounced that wrong. It says, can we explore inpatient mental health services for those up to age 25? JR is currently up to 25. And there's the impression that people with mental health needs are better off committing a crime to get age-appropriate services and settings.
Diana, is this sort of a question related to like the age limitations on the clip setting? You know, certainly obviously DCYF, we have limitations on the foster care side of the house about how old we can serve, and then the JR side, but I think this one might be for you.
Thank you. Yeah, this is Diana. It is definitely a topic that we have conversations about often on the Children, Youth, and Family team. We are limited in some cases by legal age of adulthood and Medicaid coverage to 21 for certain services, and really aware of the flux in the system between the adolescent system and the adult system. If you want to follow up, I would like to connect you with our transition age youth team to continue the conversations. There's a group of folks really looking at how do we weave these different age funding areas and make sure that we are doing a good job for developmentally appropriate services for transition age youth. It's on our radar, and I hear you, and I would love to have your input on some of the conversations we're having if you'd like to participate.
Gary, could you go to the next slide, please? So we have gone over time today, so we want to thank you for hanging in there with us. My name is Sarah Tunnell. You will get an email from me of this recording of this webinar. We just want to thank you today for participating and assisting this work group and prioritizing the work going forward. We were not able to answer all of your questions today. We had a limited amount of time, but we did capture all of your questions, and we will look at those as a work group. So thank you very much, everyone. Gary, I may need you to end the webinar. I can't do that.
I'm still copying and pasting from the question.
You don't have to do that. We can download the question log.
Are you serious?
Yep.